All right, so I'm gonna go through the information, the questions that she sent me that she had issues with. Okay, and then if you had issues with some of these things, you let me know. So one of the thing is she asked where dental liners should be placed. Does anyone think that they can answer that? When we have when we are completing a restoration and we are going to use a dental liner on a patient's restoration, where exactly should it go?
The
A
deepest
dental,
part of the deepest portion, I think.
yes, that was James.
Yeah.
Yes, we're gonna place it into the deepest portion of the tooth. Why? What's the purpose of it?
To
What does the liner help? Go ahead.
protect the pulp.
Yes, it's going to help us to protect the pulp, okay? So we place the liner in the deepest portion of the tooth in order to protect the pulp, right? Difference between zinc oxide eugenol and zinc phosphate and polycarboxylate. Hold on, I'm reading her. Polycarboxylate is what she meant, but who knows the difference between those three types of cement we spoke about? Zinc oxide eugenol, zinc phosphate, and polycarboxylate.
The
zinc eugenol has a calming oil that helps calm down the pulp.
Mm-hmm.
And the other one acts as like a base.
Okay. Technically, they can all pretty much be used as a base, right? And I think I think maybe when you guys are reading through these cements, you got to understand that when you're choosing between the three, it's really about preference number one and what's going to be best for this patient in their situation. So if you have a patient who is experiencing pain or some type of sensitivity, you may want to move towards using the one that has the eugenol in it, right? Because the eugenol has that sedative effect. But technically, zinc oxide eugenol, zinc phosphate, and the polycarboxylate, they all do the same thing. They all serve the same purpose. It's just some of them have different properties that are helpful in certain situations, right? If you really think about the polycarboxylate and the zinc phosphate, they're not that much different, okay? Usually it's like a preference. What does the doctor like to use over the other? And then of course, if you're gonna use the oxide eugenol, it's because you want something sedative. So I don't want you guys to read too much into those cements and it's like each one is for a different scenario. They're all gonna do the same job. It's just about which one is better for the patient that you're actually treating. Which one is better for the scenario that you are in with that specific patient? Is anybody confused by that? Okay.
wasn't it one that they said you don't supposed to use for people that had like prior heart attacks or something?
So that I think you mixing up with you might be mixing up with the cord, the packing cord, how some of them are impregnated and some of them are not, maybe.
Oh,
If it's
yeah.
impregnated with the vasoconstrictor, then that means it can affect someone who has a heart condition. That's a whole different subject.
Oh yeah, I mixed them up. I'm sorry.
It's okay. All right, composite shades. What are some things we said about composite shades? What are some things you have to consider when, number one, picking one? Let's start there. Does everybody understand what I mean by the shades of composite?
Yeah, the different shades you can pick to match the tooth.
Okay. How do we pick them? What are some guidelines you have to follow when you're picking a shade for a patient?
Is it like,
Use natural light.
yeah, the natural like tooth light? You gotta make it as natural as possible.
Exactly. You want to make sure that you're not using the overhead light, right? Or any other type of bright light, because that can kind of like distort the color, make you think the color looks brighter than it actually is. Okay.
I've seen that on the test. So that is the correct answer was like use like the natural light, right?
Mm-hmm. You got to use natural light. I don't exactly remember the question word for word, but if it said something about natural light, yes. Yeah. We don't use artificial light when we're picking a tooth color. You want to try to use the natural light that's already in the room. You want to make sure that when you get the different shade guides, you're going to see that some of them are going to have different numbers and letters, right? So you want to make sure you're matching the guide to what type of composite you're using. Because, for example, and I'm just going to throw out some numbers for you. Let's say you have a shade guide that says it's A3, but your composite is not in that format. Your composite has like a double B, double A, or something like that. You want to make sure you use a guide that matches the material you're working with. Because if they don't match, you're not going to be able to pick the right color. Okay. And then also you want to disinfect your shade guide. Make sure that after you use it, because you're going to put it very close to the patient's lips, it might even touch the patient's lips and their teeth. You want to make sure that you disinfect it afterwards. So we're not going to sterilize them, but you want to spray it down with the disinfectant and wipe it to make sure you're not cross-contaminating between patients. What else did she ask? And then the last thing she asked of me was etch. What is the purpose of the etchant gel?
Isn't it for the composite to stick?
Okay, who was first? Was that Breshawn talking? Who was that?
Yeah.
Yeah. What'd you say?
I said, isn't it for the composite to stick, like, onto the tooth?
Okay, so it's part of the composite process. What exactly does the etch gel do to the tooth?
Etch gel makes the tooth a little rough.
Yeah, but I say it gives it a rough surface.
Okay, it does roughen the surface. What do we say that it removes off of the tooth? I'll give you a hint. It ends with layer. What layer does it remove off of
The
smear layer.
Yes, the smear layer.
Oh,
the smear layer off of the tooth. That helps to provide like you guys said, a rough surface for that the composite can stick. All right. What is the etchant gel made of?
Is it acid?
What kind of acid?
Start with an H.
Starts with a P.
Is it how do you say it? Phosphorus?
Yes, phosphoric acid.
Yeah.
All right. And then once you etch the tooth, what would you do next? If you're talking about doing a composite, we etch the tooth. What do we do next?
Bond.
Yes, we're going to use our bond. What do we need to do to the bond in order for it to be effective?
Cure it?
We need to cure it. Yeah.
Okay.
All right. Any questions you guys have from any of the past chapters we went through? No. If you guys are not reading the chapters, can at least please go through these PowerPoints to go through this material, just so that you kind of have experience with it, even outside of these Zoom sessions. So make sure you're going. That's why I post the PowerPoints, because I know it's kind of tedious reading through chapters on your own, but at least flip through the PowerPoints. And I think if you open it up, I think Google has like a Slides app. If you open it up on Google Slides, it even has little notes on the bottom of each PowerPoint. So really, if you're not going to go through your textbook and read, take the time to go through the different PowerPoints to kind of refresh yourself on this material. Okay. So today, what we're talking about is, we're in chapter 46. We're talking about alginate. Some of you guys have experience with alginate. What is alginate? Who remembers what alginate is? I know not all of you have used it before, but some of you have. Can I get somebody, anybody? Nobody remembers what alginate is?
What was the what was alginate? Isn't that the stuff that you make impressions with?
Yes, it's the material we use in order to take an impression on our patients. I wanted to try to find a picture before I started with the slide. Right? Does everybody see my screen?
Yes.
So this is an alginate impression. Okay, so remember we have the little putty, you mix it in the bowl, the powder with the liquid, it becomes this putty material, we place it in the tray, you take an impression on the patient. So we're gonna talk about a lot of different types of impression materials, but today we're gonna focus on alginate and then we'll move on to the others on Wednesday. All right, I'm gonna just mute you guys. So all of you guys are muted. So when I ask a question, if you want to answer, you can just unmute yourself to answer. All right, so when we take impressions, the purpose of that impression is for us to kind of have a 3D representation of the patient's tooth, or teeth, I should say, of the patient's mouth, in order for us to kind of create things for them like crowns, dentures, or to just have a study model that we can look at even after the patient is dismissed, just so we can kind of create a plan for them, right? Because sometimes we can do an examination and the doctor is thinking about, okay, what is the best plan for this patient, but you don't want to have the patient sitting there for 3 hours while you try to figure it out. So there are times where the doctor will ask you to take an impression to create these models for the patient so that they can use that model later on to really sit down and complete an in-depth plan for that patient. Okay, so we have 3 classifications of impressions. So we have first preliminary impressions, okay? Preliminary impressions, what we're gonna talk about is the alginate impressions that we take. Those are usually not as what's the word I'm looking for? Not as direct, or they're not as what's the word I'm looking for? Like they're not, I don't know, I don't have words today. They're not as clear as the other ones. Like they're not as perfect as the other ones would be. Then we have final impressions. Those impressions are more like they're designed close enough to the patient's teeth that you can use them to make crowns, you can use them to make bridges. And then we have occlusal impressions, also referred to as bite registration. So this is where you just see how the patient's maxillary and mandibular teeth come together. And then for each of these different types of procedures, whether it's preliminary, final, and occlusal, they all use different materials. So we would not use alginate for bite registration, but we also wouldn't use bite registration for a preliminary impression. So you have to think about what type of impression you're taking for this patient, and that will lead you to figuring out which material is going to be best for that procedure. Okay, so preliminary impressions, they can be taken by the dentist or the expanded function dental assistant. But this is kind of inaccurate because even if you're not an expanded function dental assistant, you can take preliminary impressions. Okay, so preliminary impressions are used for diagnostic models. So those are the models that I'm saying the doctor will use just to use as a study model to kind of plan out what exactly it is that they want to do for this patient. They can be used to create custom trays, which is exactly what the name sounds like. Provisional coverage, meaning a temporary crown or temporary bridge. If you take a preliminary impression, you can use that impression to make something temporary. Orthodontic appliances, so retainers, we can use that preliminary impression to make retainers. And then post and pre and post treatment records. So if, for example, if a patient is getting like a full mouth of implants, or a whole bunch of crowns or veneers, you can take impressions beforehand. That'll show you what the teeth look like. And then when the process is all over, you can take impressions again. And that will you can use that as a comparison. Okay, so final impressions are taken by the dentist and are used to produce the most accurate reproduction of teeth. Okay, that was the word I was looking for. Accurate. Preliminary impressions are not as accurate as the final impressions are. Okay, you can, as an expanded function or as a dental assistant, you cannot take final impressions on your own. Of course, you're going to help the doctor during this process, but you're not allowed, I should say, to do it on your own. Okay, so it provides the dentist and the lab information so that they can create indirect restoration. So again, who can tell me what are some indirect restorations that we can create for patients?
That'd be veneers.
Mm-hmm.
Like
Veneers,
crown, bridges.
crowns, bridges, veneers, those are types of indirect restorations, yes. We can use final impressions to create partial or full dentures. And then also we can use those final impressions for implants. So again, because they are more accurate, because you can see more structures of the patient's tooth with the final impression, that's why we can use them for some of these different indirect restorations that are more permanent. Okay, bite registrations taken by the dentist or the expanded function dental assistant, and this just produces a representation of the patient's occlusal or occlusion, I should say, how their maxillary and mandibular teeth come together. Now, the purpose of having a bite registration is if we're creating these different indirect restorative appliances for the patient, we want to make sure that we don't create them too low or too high. We have to make sure that they're the same height as all the other teeth the patient has in their mouth, right? If we don't see the relationship between the two arches, you run into, creating something that's too high or something that's too low where the patient won't be able to bite down normally, okay? So it's very important. What you'll see is that when you're creating a crown, you're going to take the final impression, but then you're also going to take a bite registration because that's going to tell the lab how high the tooth needs to be. Okay, any questions about those three types of impressions before we move on?
No.
Was that a no, or was somebody trying to talk? Okay. So impression trays. So of course, we don't just put the material into the patient's mouth. We have different trays that we use to hold the material for us. And then also just to help keep the form of the patient's mouth, right? It kind of helps us to become like a guide. So the material itself, it has to, in order for it to work during this process, it has to be able to hold the impression material in the mouth, right? You don't want to use a tray that's flimsy or a tray that's going to break under pressure if you put pressure on it when you put it into the patient's mouth. It's going to be able to, it has to be able to hold the material close to the teeth. So you don't want one that's too wide or too flexible. Of course, you don't want it to break when you remove it. And you don't want it to warp the material. Who thinks they know what warping means? W-A-R-P, warp. What does it mean for a material to warp? You probably hear that in like cartoons and stuff.
Breakage, damage, or something? I don't know.
Close.
Change something about it.
Yeah, kind of like change shape. When we talk about warping, it's more about the shape shifting, like the shape of the material changes. So of course we don't want the tray that we use to cause the change in shape of the impression, because the impression has to be a direct representation of what the patient's mouth looks like. And if the tray causes the material to warp, then we no longer have that exact representation. Okay, so we have two types of impression trays. We have stock trays, and then we have custom trays. So your stock trays, they come in very different sizes and different styles as well. These are the ones that you would use, I would say, most often for your preliminary impressions with the alginate. So here are some types of stock trays. So stock meaning you buy them already pre-made in this way. Okay, nothing has to be done to make them. You just order them in this fashion. Okay, so they can be metal, they can be plastic. Okay, you can see this one down here, C, is the ones that we use for our alginate impressions, especially in our school. They also have, these are called triple trays, but they're still stock trays. And when you take an impression with D or E, you are able to see both maxillary and mandibular teeth together in one impression. Okay, that's why it has this little mesh. So you would put material on the top of the tray and also the bottom of the tray. And when you remove it out the patient's mouth, you'll see both arches in the same impression. So you got to pick the right tray. So when we finally get into practice this, one of the first things that you have to do is try in the patient's tray. There are time and time again where I see people like, oh, your mouth looks like a medium. Oh, your mouth is pretty small. Oh, your mouth is large. And then they'll just take the tray and not really look to see whether or not the tray fits properly. Number one, you want to make sure it's comfortable. You don't want to put anything in the patient's mouth and it's choking them, right? Or it's painful along their gum line. You want to make sure that it extends beyond the facial surface. So if you can see the facial, like the enamel of the tooth when you put the tray in the mouth, then that tray is too small, right? You want to make sure when the tray is in the patient's mouth, you're not supposed to see anything. You're not supposed to see the teeth. You're not supposed to see the marginal ridge of the gum line. Everything is supposed to be completely covered. It has to extend approximately 2 to 3 millimeters beyond the third molar, retromolar pad or tuberosity. So let's go through that really quickly. When you put the tray into the patient's mouth, you should look into their mouth, right? Because some people just put the tray, look at it real quick, and then move on. You have to look inside, have the patient lift their head back or tilt their head down so that you can see that the tray is covering the third molar. Because what's going to happen is if it's not, you're going to take an impression and then the third molar is not going to be in the shot. And then you try to create, let's say, a mouth guard for them or a whitening tray or something. And then that third molar is not going to be in that tray. When we say retromolar, it really should say retromolar pad or the tuberosity. The retromolar pad is the area of gum tissue behind your third molar, but on the mandibular. Okay, so if you got some paper, write that down. The retromolar pad is the gum tissue that is behind your third molar, but on the mandible. Okay, the tuberosity, we usually call it the maxillary tuberosity, is the same thing. The area of gum tissue behind your third molar, but on the maxilla. Okay, retromolar is mandibular, tuberosity is maxilla. Okay, so again, another criteria is that the impression tray should be deep enough to allow 2 to 3 millimeters of material between the tray and the incisal or occlusal edge. So if you put the tray in without any alginate material and it hits the teeth, and I mean like there's no space for it to go further down into the patient's mouth because it's hitting like the incisal or occlusal edge of the teeth, then that tray is not big enough for the patient. You want to, because what's going to happen is you're not going to capture the like the gingival area of the tooth. You're only going to capture the incisal and occlusal edge, and you're going to miss all of that gingival area. So you have to make sure you can seat the tray all the way down into the patient's mouth or all the way up, whether you're using maxillary or mandibular. So the impression trays themselves, well, before I move on, any questions about the criteria for selecting the trays? Okay. So the criteria, the characteristics of the impression trays, so they can come in different forms. So we have quadrant, section, and full arch trays. So of course your quadrant trays mean that the tray is cut in a way that you could only use it for one quadrant. So, and the way this works is kind of like opposite. So you can think about it, if you can think about it like how we did with the Tafelmeyer, and how the direction you placed it for the upper right was the same direction for the lower left. It's the same way with these quadrant trays. The same quadrant tray that you use for the maxillary right, you can use it for the mandibular left. And the same quadrant tray that you use for the maxillary left, you'll use it for the mandibular right, kind of like diagonal, okay? But again, those trays only cover one quadrant, okay? So 1/2 of an arch. Then we have the section trays, and these only cover the anterior portions of your teeth. So they will only cover canine to canine. You cannot use the section tray if you are trying to capture the posterior teeth, okay? And then of course we have a full arch tray, and you're able to catch an entire arch in this tray. So either the entire maxilla or the entire mandible. Any questions about this? Okay, some of the impression trays have perforations or holes in it. If your tray has holes in it, the purpose of the holes is so that the material can ooze into those holes, and then it becomes locked into place, so that when you remove the tray from the patient's mouth, the alginate impression won't fall out of the tray. Now, they have some trays that do not have these perforations or do not have these holes. And in that case, you have to use like an adhesive in order to help the material stay, okay? So these are the two ways, because what the material itself is smooth when you mix it. So if you don't have something locking it into the tray, when you remove it out the patient's mouth, it'll probably stick to their teeth, or it'll fall right out the tray. So if you don't have a perforated tray, you have to use adhesive. Okay, if you have a perforated tray, meaning there's holes in the tray, you don't have to use an adhesive. You can still use an adhesive, but it's really not necessary. Okay, so here's an example of a perforated tray here on the right side of the screen. So as you can see, it has all of these holes in it. So when you mix your alginate impression material and you place it into the tray, once you put it in the patient's mouth, the material is going to start flowing through these holes, and then it's going to harden, because that's what the material does. It hardens over time, but because it hardens in that way, it's going to lock the material into the tray. And even here, you see it has some perforations, but this tray in the middle, you see it doesn't really have a lot. So I would still use adhesive on a tray like this. Here, you see it has the perforations on the side. Okay, so this one you probably would be okay. This one over here is what we would call a quadrant tray, the gray one. That's a quadrant tray. As you can see, it would only capture one quadrant of the patient's mouth. The one in the middle is what we would call a sectional tray. So you can use this to capture only the anterior teeth. And then here is the full tray. So you can capture an entire arch with this tray. This tray in particular is for your maxillary arch. And we know it's maxillary because it has this extension here in the middle, and that extension is for it to fit into the palate. All right, this is gonna cut me off in a second. So I'm gonna post your assignment for today, and then I'll be back on at 12:30 and we can continue with the alginate. Any questions before it cuts off?
No.
Okay, I'll see you guys back later.